Please welcome Kathleen Koch back to the stage. She is joined by Dr. Mark McClellan, former FDA Commissioner and current Director of the Duke-Margolis Institute for Health Policy.
Hi, Mark. Thanks for joining us this morning.
That's great to be here, and nice to see such interest in this really important issue.
It really is. So you heard what the congressman said, or what our last guest said. When it comes to the drug shortages that we're experiencing, does that jibe with what the Duke-Margolis Center for Health Policy has found? I know you did a recent report on that.
Yeah, it does. We formed a consortium last year on drug supply chain resilience and advanced manufacturing, in part because of the worsening challenges that we're seeing in important parts of the drug supply chain and availability of critical drugs, especially for hospitals. So the reports that we've done, the ideas that we've heard about already today, Dr. Bouchon has legislation on trying to increase transparency about what's going on in the supply chain, where drugs are coming from, availability. This builds on programs that FDA already has in place. They have a whole team that monitors drug supply chain issues and tries to prepare for shortages. More information would potentially help there, but as you just heard in the last discussion, it's not just about information on the supply side and the supply chains, but also the supports available in the market for having a reliable supply of drugs. We were just talking about, everybody wants lower drug prices. Most of the drugs involved here are generic drugs, and within that, generic drugs that are hard to manufacture. They're injectables that have to be made and maintained under sterile conditions, so it's even more sophisticated manufacturing. And these are drugs that there's not patent protection in place. There can be a lot of competition to really get to low prices.
And they've been around a long time,
They've
right?
been around a long time.
I know some that have been in shortage recently.
Yeah.
Were developed 70s, 80s. But
Yeah.
Can you help us understand, why is it hitting this crisis point now? What has really happened?
Well, a lot of these drugs have been in shortage for a while. So for some of it's a chronic problem. It is getting worse, I think, because of the
record levels, right?
Record levels of pressures on the market. The majority of the drugs, the 300 plus that are in shortage now, cost less than $1 per dose.
Less than a bottle of water, right?
Yeah, we're not, way less than a bottle of water. You can't get a good cup of coffee for this price. And even the more complex, these injectable drugs, it's like $4 or $5 per dose. So one thing that's important for people to remember is that in contrast with the usual problems they're worried about with drug pricing,
they can't afford it. They cost thousands and thousands
so
of
the
dollars.
question is, in this case, where we've got anybody who meets reliable manufacturing standards can participate. It's just that the prices are such that they're not able to sustain at a large scale reliable manufacturing. So basically what's going on is that FDA takes a lot of steps to make sure that if a drug gets into a hospital and gets into a patient, it meets the FDA standards.
Of course, that's their job.
That's their job. The problem is that because the manufacturing process is complex and you have to source the ingredients and things like that, there's just very little margin. It's not profitable or sustainable for many of these manufacturers to invest in not just quality for the drugs that make it into patients, but reliability so that the drugs will be consistently supplied. And
so how do we change that?
So we change that by the things like Dr. Bouchon has been talking about on more clarity about reliable manufacturing is important. FDA has some new programs like a quality management maturity program on quality manufacturing to try to get the quality up.
But so would companies get like a quality score?
Yeah,
perhaps they would be favored.
More transparency
in the
about that,
okay.
So that when hospitals and we heard from the distributors and kind of purchasing organizations that buy drugs, just like they buy other supplies on their behalf, they'd have access to better information on not only is this drug that you're actually getting today meet FDA standards, but is this manufacturer and their distributors supplying these drugs reliably, consistently, so that the patients who need them are going to have them? This is an industry where hospital care, you need reliability for the operations, for the chemotherapy.
And
it's
quality.
Not just quality, it's quality of point in time, but it's reliability over time. So better data will help, but the other big problem is that we don't have a market that really rewards reliability. So the way a lot of these contracts for buying drugs are set up, hospitals might have, or their purchasing organization might have an arrangement with a manufacturer, but if they find a lower price on the market today, the contract's going to let them go take that lower price. And see, if everybody's buying drugs that way, it doesn't create a very good environment for the manufacturers that are trying to do it
How can
reliably.
they really run a business
Exactly.
and plan? So we need to change the way we contract?
That's right. So
Okay,
the
how
way
does that
we
work?
think of it is it's a demand problem as well as a supply problem. We've got a market that's doing a good job of getting really low prices and a not so good job of getting really reliable supply. To fix that, we need to shift the market and get availability of good information on reliability as well as quality of the manufacturers and their supply chains, and link that to contracts where the norm, not the exception, is purchasing for reliability. And there are examples of this in the United States now. Civica RX, all of the government purchasing organizations, the major ones now offer this option. It's
Now,
just
people don't know who Civica RX is. You need to explain that.
So this was an arrangement supported by, and I should be clear in terms of disclosures, we get funding from the West Health Foundation. They're very committed to trying to make essentially healthcare markets work better, more reliable, low cost, high quality care. They've supported a collaboration along with other foundations and some hospital systems to get to a reliable manufacturing supply. So Civica RX is basically committed to manufacture in the US and they've committed to supply these drugs that are often in shortage and are critical for hospitals, and they do it in a different way, which is not just, we'll produce drugs and put them on the market.
Right, not the
and hope
race
that
to the
price
bottom
will
for the lowest price.
Right. and compete on price, but we'll get into contracts with hospitals and health systems, so like Kaiser, Intermountain, participate in this program. And what they get is they pay a little bit more, but we're not talking about, thousands of dollars more. We're talking
$10
about,
instead of $8.
Yeah, or even
Okay.
less, like
Okay.
10, 20%, 30% higher. But in return for that, they get a committed contract where the manufacturer, in this case Civica, says we will supply this drug. We will face a financial penalty if we don't deliver it, every day. So there's adequate supply whenever you need it. The flip side for the hospitals is that they're a little bit more committed. They're kind of locked into paying for this contract. So that might mean, today it's $4 rather than I could get it on the spot market for $3.25. But in return for that, 75 cent, 25 cent, whatever difference in price, they get reliability and their patients get reliability.
And I understand some studies have been done that show that in the long term, that is actually saving them money, the hospitals across the board.
I think that's right. It's when you don't have the drugs that you need, and the drugs that are in shortage, there's a big cost to that. So these are drugs that are used for anesthesia, for pain control. So you don't do the operations, or if you do the operations because they're emergency operations, you're more likely to have complications. They're chemotherapy drugs for kids, for adults with serious cancers. You don't get the right, best treatment for the cancers, that's going to mean higher costs of complications afterwards, as well as patients having to stay in the hospital longer. So this is an approach that should be sustainable. It's just we need to kind of jump together to a new way the market works, where just like so many other things, as that hospitals buy, they focus on reliability. They have backup generators, they have backup staff, and all that costs extra, and it's built into the cost of a hospital. Say why? Because that reliability is something you need in these very serious services that hospitals provide for serious conditions. We just haven't done it yet for these mainly generic drugs and injectable drugs that are repeatedly in shortage and causing these ongoing problems in quality and reliability of healthcare.
It sounds like you're talking about a real paradigm shift from the fail and fix responsive mentality to really a preventative state of mind,
and
right?
I hope it's not something that people regard as too complicated. And I think the good news here is, as you heard all morning, this is an issue that has bipartisan interest. There seems to be emerging consensus around how to approach it. We're not the only ones who have been working on this. You're going to hear from a panel in just a few minutes, people from Brookings, elsewhere, who have really thought hard about this too, with solutions that are in a similar direction. And it basically includes, we've talked about good, reliable information on manufacturing quality and supply chain reliability that people can use to find reliable manufacturing and distribution partners, coupled with good contracts, committed contracts that help assure that the hospitals and their purchasing organizations, distributors that get the drugs on their behalf are buying from those reliable manufacturers. It doesn't have to be for every single contract, but just enough to make a big shift in the market. That is going to cost a little bit more, and that Senate finance bill, the bipartisan one that we're just hearing about, includes a provision for bumping up essentially the payments to hospitals when they make this shift and trying to do it in a way that's not too burdensome. So we still have a lot of kinks to work out here on getting the supply transparency right, getting the right kinds of contracts and supports and reliability in on the demand side, and coordinating all this. The White House is involved as I set up a coordination steps. HHS is coordinating across, this is FDA, CMS, our emergency response efforts at ASPE. So we're getting there, both through the steps that the administration is taking and this very important bipartisan legislation.
Congressman mentioned tax incentives. Do you think those play a role?
I think tax incentives could. The challenge here is targeting it to where we need it. So tax incentives for manufacturers that supply reliably could help, but just tax incentives for manufacturing in general, or just like increasing prices, that's probably not going to be enough. Yeah, you want to reward
targeted.
Yeah, you want to reward reliability. Just paying more for manufacturing that doesn't necessarily get reliable supply of the drugs we need isn't necessarily going to solve the problem.
What about onshoring? What are your thoughts on that?
So there has been a lot of discussion about the national security implications, not only for these critical drugs, but for all of our increasingly sophisticated advanced medical technologies. And that's a very important discussion to have. I do want to make a distinction between having supply that comes from the U.S. or nearshoring versus having a supply that's reliable. We have seen drug shortage issues and manufacturing reliability problems arise from manufacturers everywhere in the world. China and India for sure, but also Europe, United States. It's really these underlying features of a transparent market linked to strong supports and a norm of buying reliable drugs that makes the most difference. So I hope as we go forward on this, we'll think about a diverse and robust, resilient supply, but it's not so simple as just saying, well, if we just make this American, the problems will go away.
You were FDA commissioner for 2 years, and then 2 years later, you were head of administrators CMS,
Yes.
Centers for Medicare and Medicaid Services. Anything specific that those two agencies could change about the way they operate that would improve this system that you haven't already mentioned?
Yeah, I think it's some of the things that we've already talked about. So FDA, historically, if you look back at this issue over the past decade, a lot of the responses have focused on, well, the quality's low or the reliability is low. FDA want to just regulate more. So FDA set up, like I said, that quality management maturity program and steps where they can kind of document, at least on a pilot basis, which manufacturers are good. But if the demand isn't there, if people aren't paying a little bit more for reliable supply, not just quality drugs, then those steps have a hard time getting a response in industry. They can't, if they can't sustain their manufacturing at this higher cost of being reliable, then the FDA steps by themselves aren't going to make a big difference. So it's a necessary step, but not sufficient. That's where CMS comes in. CMS oversees, not just pays for medical services, and like I used to tell my staff when I was there, you're the nation's largest public health agency, right? Because how we pay makes such a big difference. And CMS right now has paid for, especially for these hospital drugs, just a whole bundled payment that doesn't pay a lot of attention to whether or not the supply is reliable or not. And the Senate Finance Bill, our proposals, some other similar proposals that are out there are all about, well, how can we change that? Have a focus, just like CMS focuses on, you've got to have reliable electronic records, you've got to have adequate staffing. What's the least burdensome way to help give hospitals the financial support they need and the accountability for having reliable supply of drugs too?
I know that your report on the drug shortage also looked at what the federal government was doing and what was working and what wasn't.
Yeah.
Because we have had more than a handful of federal agencies addressing this over the last 10 years, and it doesn't seem to have helped. What hasn't come together? What did they pass? Excuse me, the wrong measures or the right measures, and then they didn't get implemented properly?
They passed measures that were well-meaning for addressing pieces of the problem, but as we were just talking about, it's not sufficient to have higher regulation and more disclosure requirements on manufacturers about their supply practices. And by the way, there also are a lot of private sector sources of information too. U.S. Pharmacopoeia, IQVIA, they provide a lot of data on this as well. But if there's not a market that works, then that information, even if it is available, won't translate into reliable supply. You can measure things, but if the funding isn't there for people to use it, for hospitals to contract based on more reliable supply, then it won't make a difference. Recently, in the last couple of years, and this reflects some of our recommendations too, the administration has put together these different pieces like you were talking about. So FDA, ASPR, emergency response, ASPE, the planning and evaluation groups, other parts of HHS that have relevant programs into a more coordinated assessment of what's going wrong and what can each of these agencies do to help. And in the last couple of years, very importantly, Mina Seshramani, other leaders at CMS have gotten much more actively involved in recognizing that the CMS leverage here to help us shift to a market that, CMS is doing this in other areas too, trying to promote better quality, better outcomes, lower costs, not just paying for specific services at the lowest possible cost. It's a theme at CMS now. So it's putting all that together that I think is different. And then Congress needs to support it with adequate resources and the right kinds of authorities to back all this up.
Wonderful. Do we have time for a quick question from the audience? It's pre-selected. Go ahead.
This one comes to us from Randall Letter. The best available government data on shortages is from the FDA, which reports when it declares they start and end, but not the difference between demand and supply, even though such differences clearly matter to healthcare providers and patients. Is additional reporting by the FDA or another agency necessary for the identification and implementation of sustainable and effective anti-shortage measures? And if so, what measures are necessary for the FDA to report more fully about the shortage?
So there are several legislative proposals and steps that FDA is trying to implement to get more data and transparency. That QMM program I mentioned, that's about kind of the quality of manufacturers, which would really help with supporting these kinds of contracts. I think the challenge is that program isn't very well funded now, and you heard Dr. Bouchon talk about need for more transparency, and I think bipartisan congressional interest in shoring up that information side on the supply and the manufacturing of these drugs that are likely to be in shortage would help. But it's not just that. We also need information on how hospitals are buying the drugs. And again, if they're just buying mainly the cheapest drugs available today because that's what everybody else does and that's what the market currently supports and encourages, we're not going to get there. So more transparency, and this is in the Senate Finance bill, of asking hospitals, and again, I think they, working with their suppliers, the distributors, the group purchasing organizations, these are large organizations that have a lot of data on reliability of manufacturers and contract terms. So we need probably some transparency there. You know, are you, hospital, using a reliable way of assuring that your drugs are not only safe and meeting FDA standards today, but they're reliably being provided. So some transparency there. The challenge with the Finance Committee bill is we need to do this in a way that minimizes burdens on healthcare providers. The hospitals, you know, they're stretched now, and I think there are ways to do that. We've given the Senate Finance Committee some suggestions about working with the GPOs, those purchasing organizations, and the distributors who have a lot of this data anyway. So putting those two together, that's, I think, the right kind of path forward. And again, it's not just us and our consortium with these proposals, but I think you'll hear more about similar ideas soon.
All right, Mark McClellan, thank you so much, Director of the Duke-Margolis Institute for Health Policy. Thanks for joining us.
Great talking with you. Thank you all.